In 2009, the community of Libby, Montana was declared by the EPA to be America's first and currently only public health emergency. This emergency was declared because of widespread community contamination with Libby amphibole fibers, a byproduct of the vermiculite mine that was owned and operated by W.R. Grace. However, this amphibole exposure is not isolated to the community of Libby and may be affecting communities and patients near you. Libby amphibole does not present as typical asbestosis. This short 15-minute video will help you to understand how to recognize Libby amphibole disease in your practice. The EPA estimates that currently over 30 million homes across America are insulated with vermiculite products contaminated with Libby amphibole asbestos. Libby amphibole was processed in over 200 processing facilities across the nation, potentially creating environmental contamination on the same scale as what happened in the Libby community. When the World Trade Centers collapsed, their steel beams were covered with a monocoat insulation product, also contaminated with Libby amphibole vermiculite. Many people may be unaware of their Libby amphibole asbestos exposure, especially if that happened in childhood, a critical time in lung development. CARD is a nonprofit organization governed by a community board of directors. Its mission is to provide specialty asbestos health care, free asbestos health screening, and facilitate research on asbestos-related disease. Dr. Brad Black is the medical director of the Center for Asbestos-Related Disease, or CARD Clinic, located in Libby, Montana.
Problems related to the Libby amphibole exposure really floated under the radar for a number of years because of the factors of not knowing about the possibility of exposure to asbestos fibers, and then also by the fact that the x-rays of the chest of individuals in Libby did not really strike us as having the patterns of asbestosis that we were taught to look for in our medical training. Our knowledge of asbestos in those days in the 1970s and 80s relates to the experience with the asbestos-related diseases caused by chrysotile asbestos, the most commonly used asbestos particle commercially. And there was never a suggestion of an environmental problem related to asbestos. It was thought that exposures in those settings could not be adequate to cause significant problems related to asbestos. Another thing that stood out as we were following patients in Libby without the knowledge of them having asbestos exposure was that the incidence of wheezing and diagnoses of asthma and COPD were so prevalent, and this would be true not just in the smoking population, but also in the non-smoking population in Libby. The number of people that would come to the hospital needing interventions was quite significant, and yet that type of problem was not typically associated with asbestos exposure in the chrysotile exposed population. So we did not connect those problems of wheezing to any possible Libby amphibole exposure. So I guess you can say that we see what our mind knows, and all that our mind knew were the more common causes of wheezing, and so it did not occur to us that there may be some other source for this this increased incidence.
Libby amphibole fibers are chemically and structurally different than commercially used asbestos. Here, Dr. Black explains some of these chemical differences and how Libby amphibole causes unique disease.
So I'd like to talk a little bit about fibers. And there's different deposits of fibers. The deposit in the site on Vermiculite Mountain, where the vermiculite ore was mined, has a very unique characteristic. It's a mixture of 5 different chemically similar varieties of what we call amphibole asbestos. Now, why is this different? Well, when you look at the commercial asbestos fibers called chrysotile, those fibers are flexible and have a curly morphology or shape to them, and are much more suitable to put into materials such as wrapping tapes and blankets and various applications the chrysotile fibers were used for. Now think of the Libby fibers now being the type of fiber that's in the amphibole family. These are characterized by being needle-like and rigid, and it's just now being studied as to its health effects. Previous to this, most of our knowledge relating to asbestos-related disease and exposure occurs around the exposures to chrysotile asbestos because that was by far the most utilized type of fiber. The pattern of scarring that we see on X-ray caused by the Libby amphibole exposure is not the one that we have typically associated with asbestos exposure with significant disease. So that's continued to complicate the understanding of really what this fiber is doing. The typical understanding of pleural plaques being a scar on the lining of our lung caused by asbestos, it has previously been thought that they do not represent a significant, do not have significant health implications. However, they indicate some evidence that one was exposed to asbestos fibers. What we have observed in the Libby amphibole population has been a pattern of plaques that form and then are followed by a extension to a very diffuse scarring around the lining of the chest without any significant scarring within the lung itself. So as a result of this, it gives an X-ray appearance that's very subtle and does not look like traditional asbestosis.
Libby amphibole disease primarily presents as thin, diffuse, non-calcified pleural thickening. Here, Dr. Black discusses some of the radiographic changes associated with Libby amphibole.
This X-ray would be read as normal, and that using both just traditional reading by radiologists and also by being read in a very formalized fashion called a B reading evaluation. Now you'll see on the picture behind me that we have what's called a high resolution CT scan of the chest. Now on this you can see the thin lamellar pleural thickening that surrounds the lung right along the chest wall. It runs in lamellar, very parallel and lamellar flow with the contours of the chest, and is frequently easy to miss. We do have the opportunities to see these sometimes when we have to do medical procedures such as thoracoscopy to look inside the chest cavity. And you'll see in this picture, this is a picture from a thoracoscopy, and you can see a thin whitish layer over that smoothly covers the lung, and then areas where there's nodularity, which are the more typical plaques that we see on a chest X-ray or a CT. So one might see the difficulties in trying to see this very thin layer that we observe.
Dr. Black's years of experience seeing patients affected by Libby amphibole asbestos have allowed him to recognize some of the unique features of Libby amphibole disease. These include significant disease from childhood exposure to asbestos fibers, obstructive, restrictive, and mixed presentation on spirometry, a presentation of thin diffuse pleural thickening, and oftentimes chest pain associated with rapid progression.
So that I would like to then talk about this thin layer of scarring that occurs over the lining of the lung. It does have functional consequences. The people that experience this change can lose large volumes of their breathing capacity over very short periods of time, much more rapidly than one would expect to see in their exposures to, with their disease and their exposures from their chrysotile exposures. I'd like to point out, when we look at this, to keep in mind that this individual lost 3/4 of a liter of lung capacity during this 3-year time period when they underwent these radiographic changes. And the most important thing to point out here is the fact that normal lung functions are certainly very difficult to interpret in a single individual. In other words, we have a range of normal, and if somebody performs lung function tests, their functions can fall well within the norm, but is that their norm? And that's something you don't know unless you have some point where you have baseline lung functions. And so one has to be careful about interpretation of a single lung function and ascribing any meaning to it unless it's correlated with a patient and very necessary past baseline lung functions. So we've talked a little bit about the fibers, we've talked about the difficulties in recognition on the X-ray studies, but there's several features of this, in the pattern of this lung disease that's been related to Libby amphibole that really stand out. And we sense that these occur more frequently in those that are exposed to the Libby amphibole in their childhood years. The pattern that's most striking is an onset of very severe chest pain, debilitating type chest pain, a very high level that limits abilities to be functional. These observations are not well understood as to why they're being seen in this population, and that's where our current research activities have been pointed. So at this point, I would like to present a case that exemplifies typical features of the lung disease caused by Libby amphibole. I think to start with, this is a case where the individual was exposed in the childhood years, simply playing around the processing facilities and in the ore piles, and having grown up in the Libby area, and having left here in about 1980. And basically, he did the things kids did in the community, including playing around the baseball fields frequently. And he was a runner. He'd run miles a day. And when he left Libby in 1980, he was doing fine and continued to be a runner and moved to the community of Missoula. He was running well up until about 2000. At which time he was having trouble completing his running to the point where he was almost collapsing at the end of his run. And wasn't quite sure what was going on and had sought some medical advice and was thought to have some asthma. Was seen at our clinic in 2004, at which time he was short of breath with any exertion. We had looked at his studies at that time, and he had a very normal appearing X-ray, other than a few what we call plaques on one side of his chest, he really had fairly normal normal lung functions. All of his lung functions fell within the normal range. It was not thought at that time that he was necessarily having progressive disease, but clearly was having trouble with his breathing, perhaps because of asthma. He then returned within the next year, having much more difficulty, having trouble when he finishing his work and getting home, and he laid on the couch at night and on the weekends, completely exhausted. He was having increasing chest pain, and really was running out of his wind very quickly. It was within about another year, his pain in his chest became so severe, he was incapacitated with it and really had to stop work. He started on oxygen not long after this, and then within the next year, as he got progressively worse, he continued to have his severe pain, requiring a very extensive pain management, cardiac evaluations, just to make sure he was not having any chest pain related to heart disease. But his pain continued to pretty much paralyze him in the ability to do much, along with his extreme shortness of breath. His CT studies, as you'll see on the pictures behind me, do demonstrate the subtle pleural thickening that develops after the pleural plaques, and hopefully you can recognize those in the pictures. And this is what we see as they are progressing in their disease. Now, Larry unfortunately went on to go into respiratory failure, and in 2010 died with his lung disease. So in summary, Larry was a individual that had basically a childhood exposure. He had very little exposure to Libby amphibole once he was an adult, left the community, and had a fairly lengthy latency before he started developing his lung problems. By 2004, he was already unable to exert at any of the activities he wanted to be involved in. And from 2004 to 2010, just 6 years, he went from just being a fairly functional individual in every way to his death, which is a very rapid course of disease.
The nationwide distribution of vermiculite products contaminated with Libby amphibole asbestos leaves the potential for the development of asbestos-related disease from environmental exposure for decades to come. Many people are unaware of their exposure pathways. We hope that this video helps providers to include amphibole asbestos disease in their differential of patients who present with shortness of breath, obstructive and restrictive lung disease, and chest pain with unclear etiologies. The Center for Asbestos-Related Disease, located in Libby, Montana, is a resource for providers. Please contact our website for more information, including scheduling a direct consultation about patients or asbestos disease in general.